Hello everyone, welcome to my channel. So today's topic is cyst. I have collected the PYQs. You can pause the video and take a screenshot. These are only the Rajiv Gandhi University paper and that is only going to come in the exam. So I am only focusing on the Rajiv Gandhi topics, that is the cysts that have been asked in that paper. Main cysts are your odontogenic cyst. In that you have your keratocyst, then we have dentigerous cyst, we have radicular cyst, and then we have periodontal cyst also, that is your radicular cyst only. Then we also have bone cyst also, which I have written, but I'm going to include it in the next video. So the first video mainly focuses on the keratocyst and your dentigerous cyst. So let us start with cyst. So what is a cyst? Cyst of the head and neck is our topic. So we are going to start with the definition of cyst. So what is a cyst? Cyst is a pathologic cavity which may or may not be lined by epithelium. Okay, so cyst of the head and neck is a pathological cavity which may or may not be lined by the epithelium. Okay, so it contains fluid, solid, semi-solid or gaseous material which is not created by an accumulation of pus. Okay, it is a pathological cavity which may or may not be lined by epithelium, containing fluid, semi-solid, gas which is not created by the accumulation of pus. So cysts usually do not have pus. If they have pus, they tend to become an abscess. So now cyst, when lead to complication, it causes infection, pathological fractures and development of neoplasm from the lining epithelium. So cysts generally are not complicated, but when they lead to complications, they cause infections or pathologic fractures or neoplasm in the worst case. So epithelial cysts are derived from something called an odontogenic apparatus. Their remnants are epithelium trapped at the fusion line of various facial processes during development. So when the two facial processes are fusing in the development, there is a fold in the epithelium and that fold remains as a cyst. Okay, now moving forward, the wall capsule is composed of collagenous fibers, connective tissue, composing of the connective tissue. So the wall is nothing but the connective tissue. Okay, now we mainly read about the classification, which is also included in the 10 marker. So classification, what is the classification of cyst? Odontogenic cyst is further classified into developmental and inflammatory cyst. So developmental cyst is further subdivided into intraosseous, that is inside the bone, and extraosseous, which is outside the bone. Okay, now coming to the intraosseous cysts, you have your odontogenic keratocyst, you have your orthokeratinized odontogenic cyst, you have your dentigerous cyst, you have lateral periodontal cyst, glandular cyst. Then in the extraosseous we have eruption cyst, botryoid cyst, gingival cyst and gingival cyst of adults. So how I remember this is DOLOG, dology. Okay, dology. D stands for your dentigerous cyst, O stands for your orthokeratinized cyst, another O stands for your odontogenic keratocyst, L stands for your lateral periodontal cyst, and G stands for your glandular cyst. Okay, then next is your extraosseous. How I remember this is by the mnemonic BEG. Okay, BEG stands for, B stands for your botryoid cyst, E stands for eruption cyst, and both the G stand for gingival cyst of newborn and gingival cyst of adult. Okay, now coming to the next, this is your odontogenic. Okay, now coming to non-odontogenic, you have developmental cyst and inflammatory cyst. In non-odontogenic you have developmental you have intraosseous and extraosseous. So intraosseous cysts contains nasopalatine duct cyst, median palatal cyst, globulomaxillary cyst and median mandibular cyst. So if you can remember maxilla and mandible, so from maxilla you have a globulomaxillary cyst, and from mandible you have a median mandibular cyst. Then you have a nasopalatine cyst, which is near the palate, and the median palatal cyst. Okay, so this is easy to remember. Now moving forward, extraosseous cysts, you have again, see, here is your median palatal cyst, then here also you have something called palatal cyst, which is in the newborn. Then you have something called nasolabial cyst, thyroglossal duct cyst, oral lymphoepithelial cyst, epidermoid cyst, and dermoid cyst. See, this is a little complicated to remember. So what you start is from your nasolabial, nose, okay, nose, nasolabial cyst. Okay, then coming down you have your thyroid duct, so thyroglossal duct cyst. Okay, then coming down you have your oral, okay, oral lymphoepithelial cyst. Then you have your skin, that is your epidermoid and dermoid cyst. So palatal, labial, palatal, nasolabial, thyroglossal, oral lymphoepithelial, epidermoid, and dermoid. Now coming to the inflammatory cysts, these were the developmental cysts in the non-odontogenic cysts, and now we are coming to the non-odontogenic cyst, in that your inflammatory cyst. Now inflammatory cyst, you have infectious cysts, that is parasitic cyst. Okay, and then coming to non-odontogenic inflammatory cyst, in non-odontogenic inflammatory cyst you have two type of cyst, that is your infectious cyst. In infectious cyst you have parasitic cyst, and in traumatic you have, see, in traumatic there are three. One is your traumatic bone cyst, aneurysmal bone cyst, and antral cyst. One is the salivary gland cyst, antral cyst, traumatic bone cyst, and aneurysmal bone cyst. Now coming to the miscellaneous cysts. Okay, in miscellaneous cyst there are simple, there are two cysts, that is oral cyst of gastric epithelium and Staphine bone cyst, or Staphne bone cyst. I don't know how it is exactly pronounced. I think it is Staphne bone cyst. Oral cyst of the gastric epithelium and Staphne bone cyst. Okay, so we'll quickly revise. So there are three broad classifications: odontogenic, non-odontogenic, and miscellaneous. In odontogenic you have two, developmental and inflammatory, and in developmental you have two, intraosseous and extraosseous. In intraosseous you have your dology. Dology stands for dentigerous cyst, O stands for odontogenic keratocyst, then L stands for lateral periodontal cyst, another O stands for orthokeratinized cyst, and G stands for glandular cyst. Now extraosseous is BEG, B botryoid cyst, E eruption cyst, G gingival cyst of newborn, and gingival cyst of adult. Now coming to the developmental, in non-odontogenic we have developmental intraosseous, that is nasopalatine duct cyst, median palatal cyst. So nasopalatine, then you have on your palate you have your nasopalatine duct cyst, then median palatal cyst, then globulomaxillary on the maxilla, and median mandibular cyst on the mandible. Now extraosseous is palatal cyst, nasolabial cyst, down thyroglossal cyst, thyroglossal duct cyst, oral lymphoepithelial cyst, epidermoid, and dermoid cyst. In inflammatory you have parasitic, infectious cyst. So in infectious cyst you have parasitic cyst, and in traumatic you have salivary gland cyst, antral cyst, aneurysmal bone cyst, and traumatic bone cyst. In miscellaneous you have oral cyst of gastric epithelium and Staphne bone cyst. So this is the broad classification. This is usually asked in association with the 10 marker. So this majorly constitutes around 3-4 marks in the 10 marker. Now coming to the odontogenic keratocyst. See, either the classification and the odontogenic cyst is asked, or the classification and dentigerous cyst is asked. So let us, in this video I will do odontogenic keratocyst, and in the next video we will be doing your dentigerous and other cysts. Okay, now coming to the odontogenic keratocyst. Odontogenic keratocyst, these are aggressive odontogenic cysts that are derived from rests of dental lamina. Okay, so what are the rests of dental lamina? you had read in your first year, right? When there is the lamina formation or the breakage of the dental lamina. You remember your enamel organ extending, and then once the tooth is formed, this dental lamina gets degenerated, and some remnants of the dental lamina remain. So these remnants is your cell rests. Okay, so dental rests or rests of dental lamina are called so because of the lining epithelium that produces excess of keratin. Okay, sorry. So that's about your dental lamina, how the cyst is formed. So basically these odontogenic cysts, see, whenever you hear the word keratocyst, the kerato in this word, this kerato stands for the keratinized cyst. So it is keratinized cyst. Okay, so it is your keratinized cyst, and it is one thing you also have to remember, that this is very aggressive cyst, aggressive type of cyst. Okay, these are aggressive odontogenic cysts that is derived from the rests of dental lamina. Okay, these are called so because of the lining epithelium produces excess of keratin, keratocyst, so that is more keratin. Okay, now moving forward, that almost fills the cystic lumen. So the cystic lumen is almost filled with your keratin. Okay, that's why it is called keratocyst. Now coming to the characteristic features. What are the characteristic features of this cyst? First is the flattened epithelium. The epithelium of this cyst is very flattened. It does not have like a prominent ridges. Okay, it is more like flattened epithelium. Okay, now and then there is the thickness of the epithelium is very uniform, that it is 5 to 8 cell layer. Okay, 5 to 8 cell layer is your thickness of your epithelium. Okay, something like this. It's the thickness of your epithelium. Now connective tissue interface is present, and palisading epithelial cell, palisading as in they are arranged in a certain pattern. Okay, like this. This is palisading appearance of the epithelial cells. Then you have parakeratin layer, and that is corrugated. Corrugated is this, right? This one. When you draw these epithelial cells, they resemble your corrugate pattern. Okay, this basically this is your corrugate pattern, and they behave aggressively and have a potential to recur. This is very important. Okay, very important. Their recurrence is very nice. Now coming to the pathogenesis. How does this cyst occur? So mainly it can be associated with something called nevoid basal cell carcinoma syndrome. Okay, nevoid basal cell carcinoma syndrome, the NBCCS, nevoid basal cell carcinoma syndrome. Okay, this is a type of syndrome. What this syndrome does, this syndrome we will discuss in detail after this video. So this nevoid basal cell carcinoma syndrome is a PTCH tumor suppressor gene. Okay, PTCH tumor suppressor gene is supposed to potentially cause it's supposed to be the potential cause, but it is not widely accepted. So this PTCH gene suppressor is assumed to be the cause, but it is not widely accepted. It involves rapid aggressive proliferations of dental lamina remnants by maturation in PTCH. So this is actually the main pathogenesis of this keratocyst, that it involves the rapid aggressive proliferation of dental lamina remnants by mutation in the PTCH gene. So this is the assumed pathogenesis. Okay, now coming to the clinical features. Clinical features may occur at any age. The peak incidence is 30 to 40 years. Okay, 30 to 40 years. Male predilected, obviously it is male predilected, and mandible is more affected because ramus of the mandible is more affected than your second molar area, then your anteriors, and then the mandible, whole mandible. So ramus of the mandible is most affected, then your second molar area, then your anterior mandible. Okay, So now in maxilla, your third molar area is affected, then your canine side is affected. Okay. Now small cysts, that is asymptomatic, large cysts elicit pain, swelling, drainage, and neurological manifestations such as paresthesia of lip or teeth. So these small cysts that occur, so basically we are talking about the keratocyst only. When they're small in size, they're usually asymptomatic, and if the cyst is large, then it elicits pain, swelling, maybe sometimes drainage, or neurological manifestations such as paresthesia of lip or teeth. Now maxilla. Involvement of maxillary sinus is usually seen with maxilla. OKC grows in an antero-posterior direction. Okay, if this is my anterior, this is my posterior, it grows in the antero-posterior direction like this. Okay, antero-posterior direction. So with the medullary cavity bone without causing obvious bone expansion. Okay, it does not cause obvious, like very much like a huge bone expansion. Unlike the other cysts, it does not cause much bone expansion. Now multiple OKCs may be present because they again recur. If the pathogenesis is NBCCS, then there is not always one cyst. There are many cysts which are forming because of this NBCCS syndrome. Now displacement of teeth can also be seen. Displacement and destruction of the floor of the orbit. So floor of the orbit can also be destructed. Teeth displacement can be seen, and when you do like a fine needle aspiration, the lesion contains a cheesy material which is your keratin and straw colored fluid which is your lumen. Okay, now radiographic features presents as a unilocular radiolucency, that is your unilocular radiolucency, well defined peripheral rims, scalloping of the border represents variation in growth pattern. Now multilocular radiolucency OKC is also observed. Now representing central cavity having satellite cyst. Okay, now the central cavity might have something called satellite cyst. Okay, these satellite cysts are basically remnants of your what do you call this, OKC. When OKC is excised, there is some part of the cyst that is left behind which can regrow to form another large OKC. These remnants of the cysts is your satellite cyst, or basically daughter cyst is your satellite cyst. If this cyst is occurring in third molar region of mandible, then it is usually ameloblastoma, and if it is on the crown of an impacted tooth, then it is usually dentigerous cyst. Now there are also radiographic variants, that is your replacemental, develops in the place of normally developing tooth. Okay, develops in the face of normally developing tooth. Then your envelopmental cyst entirely encloses within the bone. This is your envelopmental, it is enveloping the tooth. Extraneous, away from the socket bearing areas, tooth socket bearing areas, so away. So this is away from your tooth bearing area. Collateral cyst is between the roots of two tooth. Okay, collateral cyst is between the roots of two tooth. Now next is the histopathologic features. Histopathologic features, now these are of our prime importance. So histopathologic features, we have the lining epithelium. OKC shows a thin lining epithelium, so something like this I might draw. Okay, thin lining. I have a diagram actually. Let me check. So here is the diagram. So there is a separating line of epithelium that is separating the connective tissue. Now once we discuss the histopathologic features, I will show you the diagram so that you can actually correlate. Okay, so histopathologic feature, the lining epithelium shows thin OKC. So this is your lining epithelium which is thin. Okay, very thin lining epithelium. Friable wall accompanied by superimposed infection. Lining epithelium is characterized of parakeratin. This is your parakeratin layer. This darkened layer over here is your parakeratin, which is corrugated, that is rippled, wrinkled, uniform thickness epithelium, 5 to 8 cell layer epithelium thick. Then prominent palisading polarized basal layer of the giving a tombstone appearance. So this basal layer cells, these give an appearance of palisading, and a tombstone appearance is also produced. Okay, now moving forward, you have we discussed your tombstone layer or tombstone appearance, palisading appearance, corrugated or rippled or wrinkled, parakeratin surface, rete ridges. As you can see, there are no rete ridges. Okay, and separation from connective tissue is seen. The lining epithelium separates from the connective tissue. This area right here is the separation, demarcation. So it usually peels off from the connective tissue. So cysts are formed of stratified squamous epithelium. These stratified squamous epithelium, they produce orthokeratin in 10% cases and 83% parakeratin, and sometimes both ortho and parakeratin. So the orthokeratin producing quantity of cells is 10% and parakeratin is 83%. So the orthokeratin producing cells, these are basal cell layer, cuboidal, flattened, well defined, granular. The only difference majorly is if you have your orthokeratin, you will have this granular dots on the cells, that is your pycnotic, and you will have your pycnotic nucleus as well. So cyst cavity is filled with semi-solid material. Same, if it is parakeratin, then the epithelium is thin, corrugated. This is basically your parakeratinized epithelium, and if it is orthokeratinized, you will have your granular cell layer. That's the major difference. Now coming to the connective tissue, the connective tissue walls shows small islands of epithelium. Okay, it shows small islands of epithelium similar to the lining epithelium. These islands are called satellite cysts or daughter cysts. I've told you about satellite cysts. They are the small islands of epithelium. See, you can see here this island of epithelium. These are your daughter cyst or your satellite cyst. Okay, then these represent the ends. Basically, these represent the epithelial folds, where the epithelium is folding there. These. Okay, so moving forward, we read about the satellite cysts, that is your daughter cyst. These represent the ends of folds of your lining epithelium or your cyst cavity. Now coming to the dentinoid matrix, is usually finding could be due to inducive effect or inductive effect of your odontogenic epithelial components. Now coming to the lumen is a straw colored fluid. We're talking about this area, guys, if you don't know. Yeah, so the lumen is filled with a straw colored fluid of varying amount of keratin, and we have something called cholesterol crystals. When you actually take an FNAC or aspiration, you move your aspiration, then you see these shiny crystals. These are your cholesterol crystals, and you see your hyaline bodies as well at the site of inflammation, or if you do an aspiration, you get to see. Okay, then you see dysplastic, neoplastic transformation of the lining epithelium. Sometimes it develops into epidermoid carcinoma. So the complication would be epidermoid carcinoma. Okay, epidermoid carcinoma. Now treatment. So treatment is usually surgical excision. We surgically excise the cyst. Complete excision is not possible because the wall is very thin, friable, and 13 to 60% recurrence is seen, and NBCCS associated. If it is the syndrome associated, then the recurrence is almost 67%, but if it is not associated also, it is 60%. So 7% difference doesn't really matter much. So recurrence in cases with clinically observable infection were higher. So if it is accompanied with the infection, then the cases are higher. Mandibular molars, ramus of the mandibles, have increase in cases because the cyst wall is usually left behind after surgery. It is not like done it is something which is done by mistake. So limited access, because of limited access, sometimes the cyst wall is left behind and there is a development recurrence of the cyst with thin wall lining, difficulty to enucleate, hence more recurrence. So treatment is usually three: your marsupialization, enucleation with primary closure, or enucleation with packing and opening. So marsupialization, enucleation, and enucleation with packing and opening. Okay, so that's all for your odontogenic keratocyst. Next video we will be reading about orthokeratinized odontogenic. This was your parakeratinized keratocyst. This will be your orthokeratinized odontogenic cyst. It's very small, so I'm going to include radicular cyst with it as well. Okay, thank you for watching. Bye bye.